a neurologist by training, and then I specialized in the neurocritical care, which is mostly patients who really need ICU level of care, but they have neurological condition, which is exactly what this conference and this symposium is about: traumatic brain injury. They all get admitted to a neurological critical care or neurological intensive care unit, and which is run by the neurologists who are specialized in critical care, but also the neurosurgeons. But during my time there, we also receive patients who have suffered acute cardiac conditions, life-threatening conditions, and then as you all can imagine, when if the heart is not functioning properly, the brain is not getting enough blood, and I think that's where the neurological injury starts, and patients can have all the way from comatose state to some kind of a physical disability, some kind of dependence on the ADLs, which is basically eating, drinking, grooming, or all the way to cognitive issues where their brains are not able to interact with their work requirements or anything to do with the finances. So the range of the disability is very long, and so the interesting part was that the acute condition is cardiac in nature, for example, cardiac arrest or heart attacks, but the brunt is actually taken by the brain. And even though the heart starts pumping, or the heart attack is having a circulation issue, the brain is actually takes a lot longer to recover, and that's where I think the survivorship really matters when it comes to a neurologist or a neurocritical care. So today I wanted to speak to you all about the what kind of psychological and behavioral aspects of the survivorship among patients who have suffered cardiac arrest. So I want to show you my team. So this is the big team, and this is all just local at Columbia. So there's a Alex Pasciuti, Evie, Danielle. They were undergrads, then they became different levels of training. Alex is doing his PhD in health psychology. Evie is a medical student. Danielle wants to do her PhD in the future. She did some work with narrative medicine, a master's. Angela Velasquez is someone who does all our research director stuff like the IRB. So there's a lot of, like, when you're doing studies, you need these kind of people to help you sort of like execute. Dr. Mitch Elkind is my senior mentor. He was also the American Heart Association president currently, and he is a big proponent of this heart-brain connection. And then I interact and collaborate with the group of psychologists who come from different backgrounds. They have created this center called the Center for Behavioral Cardiovascular Health, which is more like a part of medicine and also cardiology. So it's like a very unique interdisciplinary sort of work that we're going to be discussing today. So there's a group of neurologists, but then also like group of internal medicine, and also psychiatry is there, psychology is there, pastoral care is there. And then the neurocritical care folks are my partners, Dr. Klassen, who does a lot of work with disorders of consciousness. Dr. Park is bioinformatics heavy, and then Dr. Rowe has worked in coagulation after COVID and other neurological conditions. So it's a very interesting group of people who are trying to solve this puzzle. Our work that we're going to show today is mostly fortunate to be funded by NIH mostly, and currently we have several grants looking at these questions, but also going into another area of opioid overdose and how the non-fatal opioid overdose also develops similar sort of condition, and how can we use the information and the study results that we are having with cardiac arrest, and how can we use them or employ for opioid overdose patients. So there's a lot to cover, but I think we will keep it very basic and something maybe interactive. If you have any questions, just stop me and say, can you explain this further? We don't have to cover all of this, but definitely I want to basically make sure that you all understand the extra cardiac sequela, which means cardiac arrest. The word cardiac arrest has cardiac in it, but we are discussing the extra cardiac, like what outside the heart gets affected after a patient has survived this condition. And then we also looked into how COVID has impacted all of this, and see how COVID has become something that has impacted pretty much everybody across the board. And then some of the intervention work that we are doing, that, studying something in a very observational manner is one way, but sometimes you really have to think about intervention. So we also sort of like develop interventions as we are studying the observational component. So the first and foremost, what is a cardiac arrest and how is it different from a heart attack? And this is the most widely sort of like utilized slide, especially in our clinic when we see patients come back and you ask them, so what happened? And they said, oh, I had a heart attack. And you're like, you didn't have a heart attack. This was cardiac arrest. And they're like, what's the difference? So the basic difference is that cardiac arrest is an electrical problem. So it's like seizures in the brain or something in terms of electrical malfunctioning, starting to some kind of arrhythmias, and those arrhythmias causes the heart to just basically stop beating completely, and you lose your pulse. You have no pulse in your arm or neck or groin, and after that, if the brain is not getting blood, if the lungs are not getting blood, your kidneys are not getting blood, all of these organs going to going to start into multi-organ failure, and that's what the cardiac arrest is. While heart attack is more like a circulation problem, like what we have heard from people. Hey, don't eat unhealthy diet, don't smoke, don't have high cholesterol, don't have diabetes, don't have hypertension, because all of those are like a milieu for atherosclerosis, if you have heard of these terms before, and that lead to like blockaging of your arteries. As you can see in the figure, the arteries are getting blocked, and then the blood circulation is getting narrow and narrow, and that's where you start getting a heart attack. While cardiac arrest is more like an electrical misfiring. Cardiac arrest can actually most common cause of death due to cardiac conditions, and it can occur in anybody, seemingly healthy individuals, young, old, men, women, and women don't even have any symptoms when they are suffering or about to experience a cardiac arrest. So it's a very debilitating condition and also associated with a lot of mortality and morbidity. So American Heart Association, in order to see if people should survive this condition, if it happens, created a chain of survival. So the first and foremost is you recognize the cardiac condition, like cardiac arrest condition. Like how do you know if someone's, let's say you are walking um, across the street, or you are in a subway and suddenly someone collapsed? How do you know that they are in cardiac arrest, or is it just they fainted, or is it just something they haven't eaten anything since morning? Or I mean, it's hard to differentiate, and I think that's where the most the community education components come in. That how do you recognize it? Because only if you recognize it, you can do something about it. So right now, the way we are teaching people across the in our communities of Washington Heights and Harlem and other high schools, where having a CPR is sort of like a graduation criteria, is if someone's completely unresponsive, you go close to them and say, hey, how are you doing? Open your eyes, and they don't respond to you, and you think that their breathing is not normal. I'm not going to define abnormal breathing, but you feel that the breathing is not normal. The first thing you got to do is provide the high quality CPR. So I know this is a virtual session. Otherwise, I would have asked how many of you are CPR trained. But this is something we offer. We have a very big network of CPR, hands-only CPR training that you could access to. But I think the high quality CPR is what saves lives. And if you are providing CPR, you need to find someone who can find the defibrillator, because you really need to know if they can be shocked. And that's what you have seen in movies, where people get shocked and they start breathing again. So that's like the third component of this chain, which goes into the next part, which is calling emergency medicine services. They will come, they will start giving medications, and after that they come to the ICUs. So in the ICU, the treatment options are that you cool their body down, You bring their body temperature from whatever they are at, 37, 38 degrees Celsius to 33. So you cool their body down using ice packs. Now there are devices to actually bring the body temperature down. And the whole idea is that the heart has already gotten a big hit. The heart had stopped. And because of your CPR and because of the shocks, the heart is pumping now. But during this time, the brain is not getting blood. And how are we saving the brain from dying more and more? And that's what the cooling purpose is, to just shut down the brain completely, reduce the metabolism of brain as low as possible so that the brain doesn't even need that blood, the heart is not able to pump. Because even after your CPR and everything, the heart starts pumping, but it's not pumping to the limit that you want it to. So that's the cooling, which has gotten a lot of attention. As you know, Columbia actually was one of the first institutions to even employ these cooling practices at NYP system, but also all over New York. So we were the pioneers, and the neurological ICU was the first ICU to start doing this. So we have a lot of tradition to take cooling seriously, because we know that the neurological recovery has a big, cooling has a big impact to make on the neurological recovery. And because of all these measures that we just talked about, successful life-saving interventions, in last 10 years, the survival rates have gone up significantly. So before it used to be 1 out of 10. You have 10 people who have cardiac arrest, 1 out of 10 will survive. But in last 10 years, because of all these public health campaigns, if you get a shock and if there's someone who saw them, who witnessed them having a cardiac arrest, 1 out of 2, 1 out of 3 can actually survive after cardiac arrest now, even if you are in hospital when this happens, or sometimes it happens in the out of hospital situation. So huge discoveries, huge impact has been made because of public health, and people are now surviving this. In this, you can see survivor group, the 1 out of 3, 31% are able to survive if they get a shock and if they are able to get CPR. So because of that, recently cardiac arrest has become the number 3 condition for disability and for morbidity. So ischemic heart disease, which is the heart attacks we was just discussing before, that's number 1 across the board. Still, in the United States, the heart disease is number 1 cause of disability and also mortality. And then followed by low back and neck pain, which is a neurological condition in certain regard. And then also the next is out of hospital cardiac arrest. So the way we look at it, these patients never sort of existed, in our community. 1 out of 10 will survive, and we would never know what they're going through, what's happening to their lives. How do we make their survivorship better? What else do they need to have a meaningful, successful, a new normal life? So now that so many of them are surviving and being in the community, we're really interested in knowing what is needs to be done for them. So the cardiac arrest survivors are the most like emerging public health priority to see how can we improve their survivorship. So our goal is to add this 6th link. And I'm happy to tell you that 3, 4 years ago, when I had shown this slide at the American Heart Association annual meeting, it was like, what? Are we going to change the survival chain to add this new link of post-ICU survivorship? Are we really beyond the survival measures? Like, lot of work and resources have been spent on just creating the survivors. But 4 years ago, we launched this concept. Can we even talk about survivorship? Are we ready yet? And this year, the guidelines, international guidelines from the Europe, guidelines from America, they're all talking about the 6th link. So a huge success there. And we really wanted to define what this survivorship is going to look like. So didn't have to go too far. We have this model called post-intensive care syndrome, which is pretty much applicable to any patient who has come to a hospital with any acute injury, whether it's brain injury, whether it's a liver injury, whether there's a lung injury. All they have to have is that the admission has to be in the ICU, and COVID is another one of them. So a lot of patients with COVID come to the ICU, and when they survive, what all things could get affected during this admission. So the first and foremost among the patients, in the patients, is mental health, anxiety, depression, PTSD, post-traumatic stress symptoms. All of these are super common in this group of patients who have survived an ICU admission, and then now they are leaving from the hospital either to home or to a rehabilitation place. The other thing that they constantly complain is cognition. Their executive functioning, which means planning, which is a very important thing to do when you are trying to go back to work. Memory, they don't have immediate memory problems. They have immediate memory problems, or sometimes they don't remember why this happened, when this happened, and even some things before that. Attention, they have difficulty, doing two tasks at one time. They have difficulty having meaningful conversation with more than one person. So all of these things have been documented once patient has survived an ICU admission. And there's a lot of physical disability, lung-wise, neuromuscular, like musculoskeletal, the leg doesn't work, the arm is weak, and all of this, as you can imagine, affects the quality of life. People will be at home, but still not be able to live the life that they had always imagined or they have always lived before this event happened. And it's not just the patients, it's also the family members. So similar stuff has been described among families, but they talk a lot about mental health, anxiety, depression, post-traumatic stress. And of course, if the patient somehow or sometimes does not survive, then the bereavement, the complicated grief. All of these things are true events that happen to the family members, and that's why they are also known as second victim or co-survivors or wounded warriors. I mean, there have been so many ways to describe the pain that the family members are going through, even if the patient has survived. So the model has been sort of described before in other conditions, and all we did was to see if this is applicable to cardiac arrest survivors as well. So we started looking into our patients, and 6 years ago, Columbia University did not even have a database. So we started looking into like 2010 onwards, all the patients who came, all who survived, and just created an IRB and then started calling these people to see what really happened to them. So here you're seeing this term called CPC, which is like a marker for functional outcomes, like how are they doing neurologically. So CPC 1 and 2, you have to know, are the good outcomes where patients, awake, following commands, having a meaningful conversation, able to eat, able to breathe, are going home, and probably going back to work, and maybe need some guidance. So these are like good outcomes, 1 and 2. 3 is where they are like disabled. They need a lot of help with their overall day-to-day activities. So they need to go to a rehab to get some rehabilitation done. The 4 is where patients are comatose, or I don't know if you have heard of this term called persistent vegetative state, which is basically patient is lying on the bed, eyes could be open, and that's all they are exhibiting. They are not comatose, which means that they don't even have eye opening or any meaningful recovery of their initial brainstem. Just the brainstem reflexes are there. So those are the 4. They always go to a nursing home, and what we found is that those patients just never left nursing home. Either they died after a year or they were still in the nursing home. The 5 is the death. So they obviously, these people they did not make it to the discharge. But the biggest, the 2 points I want to make is that the 1 and 2, which we thought are the really good survivors, they're gonna go home and they're gonna have a great life. Even after a year, 50% of them were deteriorating for some reason, and we were very confused that this is where we, you know, you know, pat on our back saying, hey, we just look at this miraculous recovery that these patients made during the hospitalization. Everything has gone good now. We really did well. And then these patients went home, and even after a year, they were just having still a lot of issues with their day-to-day life. On the contrary, the number three, which was the disabled people who went to nursing home, and people said, well, these people will always be disabled, they actually did really well and they improved after rehabilitation. So a lot of learning happened here from this retrospective cohort of patients. And we said, we got to look at this more carefully. And we created a study called Cardiac Arrest Neuropsychological Outcomes Evaluation. This was 2016. We said every patient that comes to the Columbia New York Presbyterian Hospital, we're going to go to the patients, we're going to wait for them to wake up. During this time, we will basically develop relations with their family members, make them understand why a group of neurologists, psychologists are trying to talk to these family members and patients where the condition is cardiac arrest, right? So just the education component of this experience was, it took 2 years for the family members and the doctors and their nurses and their other ancillary services to understand why a neurologist should get involved with the care of these patients. And but we did it very successfully. People were very receptive to it, and we started getting these patients enrolled in the ICU setting. And once they wake up, which is around 10 days, and they would stay another 11 days in the hospital, we will, at the time of discharge, will get their psychosocial, functional, and cognitive evaluations, and then sort of like plan to repeat it every 6 months and see how these patients do over a period of 1 year. And also like try to see, well, because we didn't even know how many people will be alive after a year. So we also said, let's just look how many people are still alive after a year. What happens to them? Do they get more cardiac events, or is it that once you have a cardiac arrest, is it going to happen again? I mean, there's so many questions that has never been answered in this group of patients. So we thought this will be a good opportunity to look at everything very carefully. So we found this is just the cognitive impairments, and showed pretty much that patients are, 50, the numbers are like percentages. So if you look at overall how many people are affected with their cognitive dysfunction, they 59% overall at the time of discharge, which goes down to 28% of patients were still having some cognitive issue at 1 year. And if you look at the breakdown of different domains, as I was saying before, memory, attention, and sort of like executive functioning are the top three domains that are affected in these patients. Bartel is the measure of disability. So you can see 76% of the patients were dependent at the time of discharge. And even after a year of full rehabilitation or whatever they could get, 40%, 39% were still having some issues with the dependence. Depression was very common. 1 out of 3 depressed at the time of at 1 year, and 1 out of 4 had PTSD at the time of 1 year. Much higher rates at the time of discharge. Severe, the domains, the cognition, psychological, physical, very overlapping. If you look at the Venn diagram, the 25% is like 1 out of 4 had all 3 domains affected at the time of discharge, and it goes to 13% at the time of 1 year. So still, it's not that it's an acute sort of like adjustment thing that, oh, it's going to take a few months, but then you will be all good and you can live a normal life. So what we realized in the sample of 200 people, that patients still require a lot of, and this is purely observational. We didn't intervene during this time. So we were just observing how their natural courses of recovery, and we learned a lot from this experience that these patients need interventions, and early interventions, or earlier we start, the better it is for them. And we also saw that women have worse recovery at the time of discharge than men, which is, a lot to explain here. Is that the average age was 54? Is it the hormones that are basically playing a role here, which has been shown in traumatic brain injuries, or is it that women get lesser care during the hospitalization? That has also been shown. that there's a disparity in how women and men are treated when they come to a hospital with a similar condition. So there was a lot to unpack, but at least we were able to show for the first time that the cognition, functional, and psychiatric outcomes at discharge were worse in women than men. And during this time, patients were coming to my office for a research visit. I would just, they would come, they would fill out all these questionnaires, in-person cognition testing, and there was nobody to look at or talk to them. So, but I started noticing that these patients are coming with all their family members and kids, and I'm like, hey, this is a research visit for you. What's everyone else doing here in this office? And they're like, doctor, this has been 6 months. No one has talked to me about how am I doing, what's life like, and we really want to be heard. And there's a lot going on in our house, and things are not normal. And there was a lot of relationship issues. There was a lot of issues with sexual activity. There was a lot of issues with their stress and anxiety, and the caregivers and the family members were also going through a lot, and the kids who had witnessed these cardiac arrests when they happened at home have never been given any kind of debriefing or some kind of a care. So there was just so much, and somehow the system, the care pathways have not been developed for these survivors, because as I was telling you, that this they never existed before. These patients were not supposed to be alive. They had always died after they had suffered cardiac arrest. So I said, okay, let's just sit down, let's have a conversation. And I said, okay, so what's life like after cardiac arrest? And they said, walking around without a net. There was just so much uh, gap in the education and the knowledge. They said, wish I had known what to expect and how common it is. And it's not the same as heart attack. So they really had a subculture identification that this is not heart attack, and people with heart attack are awake and alert when the event happens. But with cardiac arrest, they become completely unconscious and they become comatose. So when they wake up in a very confused state in a hospital setting in an ICU, they have no idea what really happened to them, and they have no recollection of events at all. So a lot of it is unknown to them, and they think this missing of the memory really differentiates them from any other heart condition. They talked about their life being, the experience is like being very traumatic. Anxiety doesn't go away, depression doesn't go away, and there was a lot of fear of mortality, fear of recurrence. That if this happened then, and I had no idea what were the warning signs or what really happened, that means it may happen again and I would not know. So that brings a lot of this extra anxiety on a day-to-day life, where they said a little bit of heart rate goes up, a little bit of shoulder pain, and they said, "Ah, is this a warning sign? Am I gonna have another cardiac arrest?" And so they haven't found their new normal yet. And this is also discussed by Kelly Sawyer, who eventually wrote the survivorship statement for American Heart Association, that this is a very common theme after people have survived. So we said, okay, we were asking our patients who were surviving about, okay, do you feel that you have made a complete recovery after cardiac arrest? So we asked this question during discharge, and we wanted to know if people said, no, I have not recovered from my cardiac arrest. What is driving that response of those patients? And the most of it was looking at, is it cognition? Is it physical disability? Is it psychological? Is it PTSD? Is it depression? And we found that at the time of discharge, most of the people who said, I have not recovered, it was guided by the depression and the post traumatic stress status. In fact, all 19 patients who were PTSD positive, they all said, I have not made complete recovery. This was at the time of discharge, and we thought, this is too early. Once they're gonna go home, they're gonna start going back to work or school or any meaningful social activity, and they're gonna realize their cognition is severely affected. They can't think straight, they cannot remember things, or they cannot walk straight, or their leg is weak, and they were gonna forget all about this psychological burden, and they're going to start focusing on their cognition and physical. And even after 6 months, people still felt that the psychological aspect of the recovery or the survivorship is what's guiding them, guiding their response to this question as negative. No, I have not made complete recovery. So it was pretty obvious that as a neurologist, I think my skill set was more cognition, more physical disability, working with the neuro rehab, working with the neuropsychologist. I mean, that's my strong suit. But really, the patients were not pointing that. Patients wanted me to think a little bit more about the psychological side of their recovery, and that was very sort of like uncomforting because I really had to get out of my zone of like ability to do provide measures for cognition and think about psychology. And that's where the collaboration with the cardiovascular behavioral folks at cardiology and gen med, it became a really fruitful collaboration because we could bring very complementary skill sets. Return to work and participation in society is a huge issue after cardiac arrest and for any traumatic brain injury for that matter. If you look at out of hospital cardiac arrest, 57% of patients, 47% of patients do not go back to work because of various reasons. And most of it could be psychological versus cognition compared to heart attacks, where it's only 30% who initially have trouble going back to work. Also, the quality of life is poor, and we saw that mostly it's younger folks, age range 18 to 44. When they have a cardiac arrest, they have trouble getting back to their usual quality of life. And also women, as I was pointing out before, which was we also showed in our data set that women have more trouble getting back to their quality of life measures. So finally, once there was so much of survivorship work coming out, the American Heart Association and the international organization sat down and said, let's bring survivors, family members, researchers, doctors, everybody together in one room, and let's figure out what's important for who. And here I just wanted you to look at these the last row, which says within 1 year, and the circles are the researchers and the triangles are the patients and their family members. So effort from both groups, survival is important, consciousness is important, physical symptoms, ADLs, quality of life, but only the survivors and the family members point towards emotional well-being, family impact, fatigue as three key components that were not raised by the researchers. The researchers thought these things don't matter, where the patients and the family members were like, nope, the impact on the family, the emotional well-being of the patient and the family, and the fatigue component are the critical aspects that the researchers should be spending their time on. And we started looking into like, are there other conditions that are associated with PTSD? Like we were finding 1 out of 3 patients with cardiac arrest having PTSD. If you look at the heart attack, which is called ACS, acute coronary syndrome, 1 in 8 patients have PTSD. Patients after stroke, which is a neurological condition, 1 out of 4. So, but you can see that the proportions are much higher after cardiac arrest, but has been described by other conditions as well. And how? So let's say you have PTSD. So what? You have post-traumatic stress, and it's harmful in one way, but how it's harmful in the long run is what's depicted here. So what happens is that you have post-traumatic stress, there's autonomic imbalance. Your sympathetic system is going up, and while your parasympathetic system, which is protective, is going down. And that leads to increased blood pressure, inflammation, endothelial dysfunction, atherosclerosis, all of these bad stuff that you have heard of. They're all connected with our autonomic system. The hormonal imbalances that lead to increased cortisols, corticosteroids, that also very bad for our overall healthy living. And then the bigger thing is the behavioral dysregulation, which means that patients think these things like doctor's visits, physical activity, sleep, tobacco, and alcohol use. All of these things become very dysfunctional. So people, try to avoid these things while going into the excess of tobacco and alcohol use. So they think their medications remind them of this event. So we should not be taking our medications. The doctor's visits remind me of my event, so I don't want to go there. So all of those things happen also because of this post-traumatic stress. And over here, this is just a depiction of all of these things, how they all get together and finally cause another cardiac event in the future. And this is basically, I'm showing you how we were trying to build our concepts of how all of these things that initially seem like a very this acute adjustment disorder eventually could lead to further cardiovascular outcomes. And this is an interesting study where they showed that amygdala, which is a part of our brain associated with fear and associated with pleasure and associated with our emotions, that's the area which is mostly involved in this PTSD and how this leads to bone marrow activation and leads to dysfunctional immune system and inflammation. So whatever I taught you as a showed you as a theoretical concept, this study really showed it based on like a functional MRI studies and showed you that this is real and this can lead to cardiovascular disease. But it also tells you that you could identify who's predisposed to get PTSD and who's predisposed to get these bad effects of PTSD on their cardiovascular events. So we started looking into our own data set, like, okay, so if PTSD is that bad, let's look if PTSD, patients who had PTSD, which is 1 out of 3, versus the others. Did they get cardiac events? And this is just the genre of like the basic information about them, that patients were younger, people who had PTSD, they were also women, which is exactly what I had showed you before in other cohorts. And also they had higher prevalence of pre-existing psychiatric diagnosis. 10 deaths. So 1 out of, I would say, 1 out of 10 people had died, and 29 major adverse events in a group of 120 people. And we saw that PTSD led to tripling of the risk of adverse events, cardiovascular events at 1 year. So in this data set, we really showed that the recovery patterns, this is a survival curve, recovery patterns are very different for patients who develop PTSD before discharge versus who don't. So we also looked into like what are the different dimensions? Is it one component of PTSD? And during this time, we are realizing that we are sort of like defining this condition PTSD after acute medical conditions as a brand new way of looking at PTSD. This is not a typical war veteran coming back with a PTSD because they saw some stuff during the war, and now they have these nightmares and flashbacks, and they cannot go beyond it. But now they have come back home. They can go to the house, to an empty room, close the door, and it should be all gone because it was all external. But imagine a cardiac event which happens inside your body. It's an internal threat compared to an external threat. And now your heart has sort of like given out for the first time. You wake up in an ICU with a very bad situation around, and now you have problems with your stress and anxiety and cognition. You cannot run away from it. This is like walking around with a live ID, strapped to your chest. So there's a lot of like, I don't know if you guys have heard about this flight or fight response that we all have when we are encountered with a very stressful situation. Imagine living in that moment for the rest of your life. So this is how you should imagine a person surviving this event and now living with these events. And this is not flashback. They have no memory. So there's no flashback or nightmares. It's mostly the stress of whether it's going to happen again. Today, my heart has, when I was walking today, taking steps, my heart started beating faster. And that was like, okay, I got to calm down. I think I'm taking it too, I should not be doing this. This may not be good for me. All these questions leads to this heightened sort of like cardiovascular reactivity and disordered, behavior. And that can explain why the patients have cardiac events. So in the interest of time, I want to show you about what we're doing for the clinic. And this is Neurocardiac Comprehensive Care Clinic. And this is where we really sit down with our patients and their family members and really have this conversation about like what is bothering you, what is going on, how can we make it better. And so the focus is to not just do evaluations but also educate them about what has happened to them, try to see if we can build their resilience, because there is a level of predisposition. A lot of patients, because of this condition, develop neurological complications like Parkinson's disorder, seizures, convulsions, spasticity, which is a very like tight leg, cannot walk anymore. All of these things happen, and we're in a unique shape to help these people. And we're really trying to build a model of one-stop shop, and that's where this is our model. So like the survivor and the caregiver in the middle, in one room, neurocritical care, myself, neuropsychology, someone who has interest in and experience with cognition, patient care services and pastoral care, who can actually understand what happens to the family, excuse me, and then also like resilience building, my research coordinator, which is basically most of the time a student, like an undergrad or a postbac, and they're doing all these assessments from the patient and understanding how it's all unfolding, and then neuropsychiatry, like really understanding the psychological side of it. And now we have pharmacy added to this mix because we really want to make sure that we touch upon every part of the recovery and then try to see how can we improve. And oh, this is the picture is cut, but this was showing that one of our first patient to the clinic, she basically, learned and also recovered a lot through our clinic, and she was very kind enough to talk about our clinic. And Columbia Medicine has mentioned it several times about how this is making differences. And we saw in our first 106 visits that patients who really come through our clinic do much better when they are just followed up in an outpatient setting. And we diagnosed patients with psychiatric conditions. Patients got their MRIs done. We had EEGs done to wean them of their seizure medications. We had referral processes, and really focused on physical health, mental health, social health. And people really had a good impact because of just. And I had no idea that the clinic itself will become like an intervention itself. So now we have the capability of the Zoom. So we have completely revamped it. Now it's a tele rehab model. We give them the gene active, which is more like a accelerometer wearable technology where we can understand their physical activity and sleep. And obviously, the clinic is free because we really wanted to cater to every part of the community. So the health literacy, as you know, is a big issue, and so really low socioeconomic status and race ethnicity has to be factored in. So, and NYP has done a really good job with that, and we are able to provide this completely free. They have given us ways to go to the community, and if they don't have internet or Wi-Fi, we are able to even provide that. So really need to close this digital divide, but that's where we are. And I would just stop right here and give an opportunity for everyone to ask questions, because I think otherwise we can just keep going because there's so much we would love to talk to you all. So feel free to ask questions. You can just unmute yourself and ask a question. Right, Wadzi? They don't have to wait for anything.
Yes. They can type in the chat. They can also raise their hands or even unmute themselves. That's also an option.
Okay. And again, this is totally open to anybody who wants to work with our group. We have 5 postbacks, 3 undergrads, all from Columbia, and then 2 medical students. Uh, then our research coordinators to execute the study. And I didn't show, but there's a lot of intervention work that we're doing that where you can learn a lot about how to do even research, how to work for these things. And also the clinic is um, all of this is, the clinic is completely run by the students. I am barely the supervising. I've gathered these providers, but most of it is run by the students. So how did I, the question is by Eric, is how did I get into this line of work? Patients. I had a patient, she was a young jazz musician in New York, and she was, you know, sleeping. She would get these sort of like nightly sort of panic attacks diagnosed by a psychiatrist. And even she had seen a neurologist. She was from Israel. And then she came, and one night she was having a similar event while sleeping, and the boyfriend sleeping next to her was like, oh, this is her usual thing. And then after a while, he realized she's not breathing. And he sort of try to do wake up, and there was no response. And then he called 911, but he did not provide CPR. As I was telling before, you really just have to start providing CPR. And by the time the EMS came, she was had gotten a lot of brain injury from that event. She came to us, and it was pretty obvious from the description that she was basically just having seizures, and seizures could lead to cardiac arrest, has been known and described as this way. And we were it was unfortunate, so we finally we cooled her as I was describing before, and then we called her mom eventually from Israel, and then we had to withdraw care because her brain was completely damaged. And then I realized that even though her initial condition was cardiac arrest, but it was caused by a neurological condition. And once she was in the ICU, it was all about the neurological recovery and the brain injury. And the brain injury is the cause of a death. So it is a neurological condition. So then I got really excited and interested about cardiac arrest as a disease condition. And that's how it all started, which is like more than 7 years ago. So another question, could you give the name of the clinic? This is Neurocardiac Comprehensive Care Clinic. And if you just Google N4C, so Neurocardiac Comprehensive Care Clinic, you will see N4C, and just put my last name and you will see the link to our clinic. And it's for all the people who are being discharged at NYP, through NYP, and even after. Now people have started reaching out directly from different states and different places because they have read about our clinic and how we are working towards good survivorship. So that's the name of the clinic, Neurocardiac Comprehensive Care Clinic.
Agarwal,
Yeah.
there's Susie with a hand raised. I'm not so sure if she still has a question.
Okay. Let me see. Susie, go ahead if you have a question.
Sorry.
Otherwise, yeah.
I'm here.
Please.
My father had suffered a cardiac arrest event in 2010.
Yeah.
And he went for a very long time without oxygen. The doctors in the ER had said that he had gone way too far with no oxygen, almost were not able to resuscitate him. And he was resuscitated. However, we were told he would never either come back or gain consciousness, or if he did, he would never be the same. He has managed to work extremely hard. He went through a long time in the hospital, but he has come back and done. He's done amazing. Nobody would know that he had ever had the issue had it not been if they didn't know him ahead of time. He was, he's one of the smartest people I know. He was an environmental engineer and a lawyer. And so he still suffers with a lot of memory issues.
Yeah.
And I think he also suffers from psychological factors into it. Do you believe that there are therapies and ways to improve that at this point, to 11 years later? Yeah.
Yeah. So how many years again was it?
It's been 11.
11 years. Yeah. I think, and that's what we are finding out. So we work very closely with the Sudden Cardiac Arrest Foundation, which has a biggest database of all survivors and their family members, and the people who run this really are dedicated to this, and people have been there for many years. Like the person who I was trying to show, whose picture got cut off, it's 7 years since her event, and she was the Columbia NYP patient. Even now, she's part of my advisory. Like, I have an advisory group of all the survivors and caregivers that I've taken care of, so that we run through every intervention, every diagnosis through them, so that we can learn a lot from them. And every time she comes on the call on that advisory, she starts getting red and her hands get very sweaty, and she says, I don't know, when will this be over? I mean, why? I mean, this is already 7 years. I know what I'm doing, and she's back to work, and she has the kids, and everything is back to normal. But as I was saying, this post-traumatic stress is real. And yes, there are interventions, there are therapies, cognitive behavioral therapy. And if you can reach out to me, I can type my email address here in the chat. We can connect you with people who are working in this direction, and it's a real deal. I don't take these things lightly.
Well, thank you very much. And the other thing I was going to comment was that I found very interesting, because I was pre-med in undergrad, and and I'm working now with a TBI organization. But I just recently, within the last 2 years, found out that my father had suffered a TBI. And I was there with him in the hospital, in the ICU, almost every waking second that there was, for, I don't know, a month at least. And nobody that I recall ever mentioned that he had a TBI. All that we were told about that I couldn't recall was about his heart and, physically what was going on with him, but never anything mentally or neurologically that was going on. So I'm glad that there are people out there that are really pushing to advocate.
This is a real problem. This is exactly, it took me 2 years to just simply provide education to the doctors and the nurses. These are the people who should understand or could understand this condition way better than, a primary care physician outside who has no connection with this condition. And when the patient comes to their clinic and say, well, I had a cardiac arrest and I'm having these issues, they're like, aren't you happy to be alive? I mean, what are you talking about? Why are we discussing this? And they think that these patients are just, too needy or too demanding.